Welcome to another sequence of the physical exam. Today we'll talk about the ear, nose, and throat exam. As we've reminded you before, the physical examination should have an orderly structure to be followed almost religiously, at least when starting out. This approach helps reduce the numbers of errors of omission. There's no specific order, and each physician may set his or her own sequence. However, by convention, an examination usually starts with the head and neck. We did not do that in this course because we tried to relate our sequence to your experience in anatomy and began with the torso. In your community trips this spring and next year, you should have ample opportunities to practice the head and neck examination because community physicians tell us that as many as 60% of walk-in patients to primary care facilities have ear, nose, and throat problems. First, we'll talk about the inspection in general. Inspection should include a general observation of the head and neck. The physician is looking for asymmetry, swelling, discoloration, or skin lesions. This is followed by specific inspections of individual structures. We'll start at the ear. Begin the examination of the ear by inspecting the external ear for redness, inflammation in other words, swelling, tenderness, or nodules. Look behind the ear. This is a favorite place for basal and squamous cell carcinomas. The otoscope we're using is a pneumatic otoscope with a lens that closes over the head. This provides a tight seal which allows pressure to be applied by a pneumatic bulb to the tympanic membrane. Because the pars flaccida does not move when there's increased pressure behind it, this maneuver, called pneumatic otoscopy, allows you to assess pressure behind the eardrum. Another type of headpiece that you may see is a dissecting head. This allows you to remove wax or other foreign bodies with the curette more easily than through the pneumatic head. Most of you will more likely become familiar with the pneumatic otoscope, however. The lens may also be removed here to allow for curettage, but curettage is more difficult through the pneumatic head. Curettage must be done carefully and gently because of bleeding and pain to the very sensitive ear canal. Next, the otoscope is used to look at the external canal and the tympanic membrane. When examining children, you may be told to hold the otoscope with the handle pointed upward. In this position, you can post the head with the little finger, which prevents injuring the external canal when the child suddenly moves. Most physicians examining adults, however, hold the instrument with the handle pointed downward, using the index finger as the balance point, just below the head of the otoscope. Adults don't usually jump around as much, so you have to worry less about sudden unexpected movements. To examine the external canal and expose the tympanic membrane, pull up and out on top of the ear. This straightens out the shallow curve of the external canal. Use the biggest speculum that will fit. The very sensitive canal is innervated by 5 nerves. A small speculum can cause pain by slipping too far in towards the tympanic membrane. Hearing can be tested by rubbing your fingers beside the ear or by whispering from about 2 feet away. Failure to appreciate these sounds is gross evidence of hearing loss. Discrimination between conductive and nerve deafness can be made by the Weber and Ryan test. To perform the Weber test, place the vibrating tuning fork in the midline of the forehead. Normally, the sound is heard equally in both ears and is interpreted as being heard in the midline. To perform the Ryan test, first place the vibrating tuning fork on the mastway process, and then when the patient can no longer hear a sound, move the still vibrating fork in front of the auditory canal. The patient can still hear sounds because air conduction is greater than bone conduction. Be sure, however, that the vibrating tines are directed towards the ear. Next, we'll go to an examination of the nose. To examine the nose, use the biggest speculum in your diagnostic kit. The best examination is done using a head mirror and a handheld speculum that can be opened and closed. However, with equipment in your diagnostic kit, one can get a reasonably good look. Not as good as one will get with the head mirror, but better than no exam at all. Without decongestion, one only does anterior rhinoscopy. To see further back, one must shrink the mucosa. Look for bleeding masses and the color of the mucosa, which becomes very pale and covered with thin discharge during the allergy season in some patients. Next, examination of the oral cavity. Because of convenience, we also use the otoscope to look at the oral cavity. even though the light is barely adequate for that purpose. Establish a routine to be done every time. Ask the patient to open his or her mouth wide. Make a general inspection, then retract the cheek with a tongue blade and look first for Stenson's duct, the outlet of the parotid gland. Look under the tongue for the dorsal veins, which lie on either side of the frenulum. Around them exit Wharton's ducts from the submandibular glands. Depress the tongue with a tongue blade laterally against the tongue. Have the patient say ah, which exposes the posterior pharyngeal wall, on which appear little studs of lymphoid tissue. This also tests the 10th cranial nerve, which lifts the palate and exposes the back of the tongue. Look also at the tonsils and tonsillar fossa. Next, expose the retromolar trigone by sliding the tongue blade laterally to the tongue and pushing the tongue medially to see the space between the gum and the tongue. This is a favorite hiding place for the carcinoma of the floor of the mouth, especially in tobacco chewers. Handle the tongue blade almost like an artist would use a brush. One needs to push firmly on the tongue to retract it. Remember, however, that some masses are better felt than seen. On occasion, one may have to palpate the floor of the mouth with the gloved hand. Next is inspection of the neck. Inspection is a very important part of the thyroid examination. Sometimes the first clue to a possible problem comes from observation of the swelling in the neck. The evaluation of the neck varies from physician to physician. Some evaluate the neck and thyroid anteriorly, and some from behind. The female larynx is a whole vertebral space higher in the neck than in the male. Thus the cricoid, the thyroid shield, and the hyoid bone are also higher. You can feel the hyoid bone between the angles of the jaw, and below that the thyroid shield and the cricoid. In the female, the cricoid is the most prominent cartilage, and in the male, the thyroid shield, or the Adam's apple, is usually the most prominent. Just below the cricoid, one can feel the isthmus of the thyroid. Use the palms of your fingers. Feel the ribbon of tissue that lies between them. This is the isthmus of the thyroid. In the anterior approach, stabilize the thyroid with thumb of one hand and palpate the lobes of the thyroid with the fingers of the other. Using the posterior approach, one can retract the sternocleidomastoid with one hand and palpate the lobes of the thyroid between both hands. One can feel the size and nodularity of the thyroid. The thyroid moves upward with swelling. Therefore, having a patient swallow during examination helps to identify the thyroid. Because it's difficult to swallow more than once or twice in rapid succession, physicians often use a cup of water to aid in swallowing. Next is an examination of the lymph nodes. Examination of the lymph nodes naturally follows the thyroid examination. We routinely examine the following group of nodes in the head and neck: the submental nodes, the submandibular nodes, of which the tonsillar node is one particular one, the anterior cervical nodes, the supraclavicular ones, here remember the sentinel node, the posterior cervical node, the posterior clavicular node, the occipital nodes are the main ones. Use the pads of the fingers to palpate these nodes by pressing them against underlying structures. First, feel for a small collection of nodes in the submandibular area, and then move to the nodes at the angle of the jaw, one of which is sometimes called the tonsillar node. This node drains the tonsils, the floor of the mouth, and the base of the tongue. The anterior cervical chain is palpated along the sternocleidomastoid muscle. Stabilize the neck from behind and push against your fingers. In palpating these nodes, be careful not to massage the carotid artery too vigorously. One does not want to obstruct blood to the brain, especially in older people. Above the clavicles, there's a cluster of nodes called the supraclavicular nodes. On the left side can be found a node, the sentinel node, which drains the thoracic duct and gives indication of abdominal or pulmonary pathology. There are a group of posterior cervical nodes unpredictably scattered along the posterior neck, which drain the scalp, neck, and mastoid area. Lastly, one should palpate posterior auricular and occipital nodes. Lastly is the examination of the sinuses. The sinuses may be evaluated by palpation and transillumination. The usual sinus problem, such as infection and inflammation, cause tenderness and mucosal thickening and increased fluid in the sinuses. Direct palpation for tenderness is possible over the maxillary and frontal sinuses, but not ethmoid and sphenoid sinuses. Transillumination is diminished by mucosal thickening or fluid. The maxillary sinuses can be compared by observing transmission of light placed at the infraorbital rim and shown through the maxillary sinus to the hard palate, which is observed through the open mouth. This procedure is done in a darkened room. Alternatively, but a little bit less satisfactorily, place the light in the mouth and look at transmission to the outside this time. Frontal sinuses can be compared by shining a light from the infraorbital rim through the frontal sinuses. Unfortunately, development of the frontal sinuses is not uniform. Normal variants can be confused for abnormalities. Again, I hope this has been a useful overview of the ear, nose, and throat exam, and hopefully you'll have a chance to practice these exams in the community, and then hopefully also come back and review these tapes to get more of an understanding of this exam. Good luck.